Following local traction mobilization to L3, L4, for a patient who has pain with flexion, a hypermobility at L4, L5, and a hypomobility previously detected in our joint segmental testing at L3, L4, we're going to want to provide a flexion glide mobilization to L3, L4, in this case on the right side. In order to do this, we're going to first want to preposition the patient to where we can lock the segments around the segment we're treating and reduce the chances of pain with mobilization in the pain-producing segment. So, the first thing we're going to do is preposition the segment below where we're treating at the pain-generating segment in L5, S1. To do so, we're going to place the patient in extension because flexion causes pain. We're not going to rotate that segment, and ultimately, we're going to produce flexion through the caudal segments at L4 on L3 by pulling the right side pelvis down. So there will be some left side bending occurring at L4-5 and L5-S1. We won't incorporate a rotation because of what it might do to the rotational behaviors at L3, L4, so we'll simply lock at the end range of side bending L4-5 and L5-S1. Now, above L3-4, we're going to want to use some movements that will lock L2-3 and above and then accentuate the mobilization we want at L3, L4. So, at L3, L4 and L2-3 and above, we're going to flex the segments. In doing so, we produce flexion in the segment that we're wanting to improve flexion in the first place. Moreover, we can use a rotation at L2-3 and above to help lock those segments. We will, because we're side bending to the left at L3-4, L4-5, and L5-S1, we would be best helped if we side bend to the right at L2, L3. If the patient is flexed, side bent to the right, then we could best lock those segments by rotating them down to or through L2, L3 to the left. We're not going to allow L3-4 to rotate, and we're not going to use rotation here at L4-5 and 5-1 because we're not sure how the segment we're mobilizing couples. As a consequence, we'll stop the rotation at L2, L3.